Thank you for the invitation. The green one. I'll say something about one of our cases, a patient aged 44 with a quasi-permanent rash, sometimes itchy, since adolescence. She had an episode of septic meningitis at the age of 25, and she had hypoacusis since the age of 20, and also an intermittent conjunctivitis. She had superficial AFD, and she said that she had frequently fever periods during childhood, but later she had frequently chills and sweating, more often visceral. They were triggered by stress or by cold exposure, or also by hot weather. And she also complained of myalgia, arthralgia, sometimes with intermittent limb swelling that we could not document, but she really described it as having a one-day duration. And she also had irritability and malaise and headache, and she was treated because she went to the allergologist. She received a lot of medications for allergy, which was not very helpful, unfortunately. She was not able to tolerate cortisone because she became very agitated because of that. So, sorry, I'll go back. So, she had an emergency presentation for a flare when she had a slightly elevated CRP and some leukocytosis with neutrophilia. But between the flares, the CRP and the SAA were normal. She also had all the battery for our immunological tests negative, including the anti-cyan-Q. Of course, we suspected her of urticarial vasculitis and of Church-Strauss syndrome. She also received a cure of azathioprine, but with no effect. Actually, we thought about Muckle-Wells syndrome with all this clinical picture, and we performed the genetics, which were, to our surprise, not very conclusive. She had two variants of unknown significance in the genes ALPK1, which is also described in Marshall or Pifapa syndrome, and another gene described in the Lynch syndrome, another variant of no significance. But we tested the IL-1 beta, which came out 9 times more than the upper limit of normal, and this is the audiogram of our patient. We thought that she still might have a Muckle-Wells syndrome because she fulfilled some of the clinical criteria described previously by Professor Aftin, and she had this urticarial rash, this cold or stress trigger episodes, and sensory neural hearing loss. And although she didn't have chronic septic meningitis, she had a single episode of documented septic meningitis, and she had that frontal bossing. And also, regarding to the non-confirmatory NLRP3 phenotype, she still fulfilled the criteria. Because other types of disease were ruled out, she had a slight elevation of acute phase reactants during the flare, and she had at least 6 months of follow-up without spontaneous improvement of the symptomatology. So, because we were fortunate enough to have anakinra because of COVID, we started to treat her in the hospital with anakinra, and her clinical status really improved. And she had a disappearance of the rash, but unfortunately we could not give her for long the medication outside the hospital. So she started to have again the flares. The flares are the previous ones. So then we started canakinumab, and the IL-1 decreased to the upper normal limit. This time The analysis was performed in another laboratory, and the limit was slightly surpassed, but it was almost normal, and she had a partial systemic response with no fever or chills, with this type of rash, the second one that actually was probably present before, but it was not very obvious at the first examination when she had that type of urticaria. The urticaria-like rash was very much improved, and the rash, this liver rash, was very similar to what we see in DADA2, or in Sneddon syndrome, or in some case of lupus, this Riveda-Racemosa-like rash. Because the irritability was persisting, we performed the dose escalation, and after the dose escalation, she didn't have any systemic complaints, the malaise improved, and she had normal biological parameters, and also the headache improved, but the irritability persisted. So she scheduled for the neurological assessment with some CNS imaging, and also she scheduled for the ENT reassessment. A few words about autoinflammatory diseases in adults. Sometimes they are true with onset during adulthood, like Schnitzler syndrome, which is very similar, as it was said before, to CAPS. At some other times, there are the onset is during childhood, but only currently the patient could have been diagnosed with the current genetic tests. Sometimes there are more discrete phenotypes with germinal mutations, with reduced penetrance or somatic mutations, with different level of mosaicism, which may influence the quantity of the mutation that may sometimes become clinically relevant. And it seems that acquired mutations may be not so uncommon in late onset symptomatic patients, and they are up to 8% in the patients with relevant clinical symptoms in a series. So the phenotypic spectrum of these NLRP3 autoinflammatory diseases is likely related to the germinal or mosaic status and to the localization of the underlying mutation, as it was shown before. CAPS has not a very well-defined prevalence. It might be very much underestimated, but it's not known. Probably 2.7 up to 2.7 per 1 million. And the phenotype is mostly FCAS in North America, and in Europe is mostly Muckle-Wells. In North America, this is due to the founder mutation. And there are several types of responses, and the dominantly clinical picture may influence also the response to therapy. There are cases described in Eurofever in also responding to bisphosphonates, like in osteitis, or responding to some other medications. That everything was tried. Anti-TNF, of course, because they were available before, but the anti-IL-1 medication is the one that seems to be the most effective. There are some other types of familial cryoperinopathies. The FCAS, actually there are 4 types, apart from these 3 phenotypes that we start to be familiar with, like syncanomid, Muckle-Wells, and FCAS. There is also the FCAS2, which is due to NLRP12 mutations. It was called before the fever of Guadalupe. The fever here is longer than in other types of FCAS. It may last up to 2 weeks. And may have this disease may also have a similar rash that may mimic lupus. Also evolves with hypoacusis, and CRP is frequently normal in this type of disease. And other familial types of rashes and fevers induced by cold are FCAS3 due to due to mutations in PLCG2. which also evolves with cold-induced urticaria, but here the ice cube test is positive, and this evolves with often with infections such as sinusitis, pneumonia, or angioedema, and other autoimmune diseases. We thought previously that our patient might have something like that, but actually this is a disease that has other type of presentation, and the more newly described FCAS4, which also evolves with intestinal symptoms and may evolve with macrophage activation syndrome. Just to remember, as pericarditis may be a recurrent pericarditis may be a minor form of PMF, there are also at the end of the spectrum the newly described DFN34, the deafness autosomal dominant 34 a disease, a milder disease in the same spectrum, and the keratitis fugax hereditaria, which are organ-restricted inflammation caused by NLRP3 mutations, so we may think about this. And there is also the Schnitzler syndrome that probably we are more familiar about, or this adult onset autoinflammatory disease due to monoclonal gammopathy, IgM or IgG, which may have a similar clinical picture like cryoperinopathy, but may have also the scintigraphic bone enhancement, and it responds also to anti-IL-1. I won't say too much about the urticaria rash in cubs, which was described very well before. The infiltrates are also neutrophilic, and leukocytoclasia is frequent in biopsies, but no fibrinoid necrosis of the small vessel walls are noted. And because many of us are clinicians here, some other diseases that involve the ear, eye, and the central nervous system. Of course, we should rule out infections, autoimmune diseases like sarcoidosis or vasculitis, and the list here is longer. Relapsing polychondritis may mimic this type of involvement. Cogan syndrome involving with interstitial keratitis and vestibulo-auditory dysfunction. A disease that is not so rare. We are seeing it more and more often. This Vogt-Koyanagi-Harada syndrome evolving with panuveitis, hypoacusis, with episodes of meningism, but with vitiligo, of recent onset vitiligo or poliosis. The Susak syndrome, also called secret from small infarcts of cochlear, retinal, and encephalic tissue, which is a retinocochlear vasculopathy. Of course, the ANCA vasculitis, Takayasu or Behçet syndrome. And of course, we should remember also the cryoperinopathies, like Muckle-Wells and the other types of the FCASs. And I won't say more about how to monitor disease activity because this was described before. Actually, we don't have specific laboratory markers. There is no consensus as far as I know regarding this. We should test probably for the calprotectin, but not the fecal calprotectin that we are using. We should test it in serum. And we also should test for this calgranulin, the S100A12. We were lucky enough to test the IL-1, but this is not a standard of medicine. I don't want you to remember that IL-1 should be tested on a regular basis, because we were lucky enough, as I said, to find it, but there is no reliability. It's used only for research purposes, because it should be searched for in stimulated full blood cells. There are some instruments, the clinical instruments seem to function. We should use on a larger scale the autoinflammatory disease index. Professor Avcin has talked about before, this one, and the threshold is 9 to differentiate between the active and the inactive disease. But there are also some other clinical measures like the patient mood score, the patient performance score, besides the other regular measures. And the Muckle-Wells severity depends on some risk factors, including the female sex, the hearing loss upon presentation, and the musculoskeletal symptoms that our patient had. There are some challenges regarding CAPS, some diagnostic challenges. There are several NLRP3 variants, out of which some were proved pathogenic, mostly located in the exon 3. But there are atypical multisystemic phenotypes due to low penetrance variants, due to somatic mosaicism, or to inconclusive genetic testing. And until recently, it was said that in 1/4 of the cases, no NLRP3 mutations can be detected, like in our case. There are no currently certified markers, and the overall inflammasome activity does not correlate with disease severity, mainly in patients with neurological features. This could be a challenge. We do not really know that our patient has an inflammation-related neurological clinical picture. And there are also some therapeutic challenges, but it is currently known that the anti-IL-1 therapy is the therapy which works the best for our patients, but therapy should be individualized in every case. However, it appears that some symptomatic patients with low penetrance variants are at risk to achieve an inferior clinical response, only a partial response to anti-IL-1, because inflammation may be mediated by other pathways such as IL-1 beta plus NLRP3 independent IL-6 or TNF alpha production. That's why we should try the things that we think that are more likely involved. There are some other therapies under development. Some of them are quite surprising. In animal models, it seems that high dose of pump inhibitors like omeprazole or some others in high doses, up to 5 doses we are using intravenously, may have an effect to inhibit the NLRP3 activation, and there are some other types of inhibition during with small molecules targeting this pathway and others. But anyway, we should start to think more of these diseases. Thank you.